Promoting health equity and wellness is our episode topic. In this, our third episode recognizing Black History Month on the BRG Nurse Executive Podcast channel. My guest is Dr. Piri Ackerman, Professor and Associate Dean for Student Affairs and Inclusive Excellence at the Betty Irene Moore School of Nursing at UC Davis, and Program Founder of the Summer Health Institute for Nurses Exploration and Success, also known as SHINES. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Piri, thank you so much for joining us today.
I'm happy to be here. Thank you, Nick.
This is our third and final episode in February celebrating Black History Month. In our previous two episodes, we talked with a panel from the Network of Black Male Nurse Leaders, first about stories from Black nurse leaders, and then our second episode was about growing and developing Black men in nursing. But today we're going to be talking more about promoting health equity and wellness and how it's important for all nurse leaders to think about that as they're thinking about diversity and inclusion practices within their area. But before we get started, can you share a little bit about your journey into nursing and what inspired you to pursue leadership and your academic roles?
My journey began fairly early. In fact, I just found a handwritten paper that I had submitted to my nutrition class in about 1989, where I was grappling with the idea of health disparities. Why is it that people can have different health outcomes based on race and ethnicity? That got me very intrigued. I've always been interested in healthcare. Nursing was the perfect fit for me because it addresses the social and psychological side of health, while it's also grounded in some of the sciences like physiology, anatomy, pharmacology. That just seemed like the perfect thing for me. And over time, being a nurse, again, I began to see some of these health disparities that were happening. Sometimes it's based upon race, gender, socioeconomic status, rural versus urban. And it brings together an epidemiological line of thought for how do we improve healthcare, not just for the individuals that are in front of us, but at a larger scale. And I think it was that latter point that got me interested in academia and leadership. Through research, through education, I'm able to reach more people. Through leadership, I'm able to contribute to changes in health policy.
Your title is Associate Dean for Student Affairs and Inclusive Excellence. What exactly are your roles and responsibilities with that title?
With student affairs, it's really about our practices around recruitment and admission processes and progression throughout a student's journey. And the inclusive excellence is about making sure that people understand that their background, their identity is value added. No matter what their background is, that each person that comes through our program has something unique to contribute to nursing: perspectives, personalities, superpowers that people might have, personality traits. All of that is of benefit if we leverage it in that way, if we're willing to share and engage and take risks in the way that we're thinking and grappling with health problems. Really, that's the only way that we can solve healthcare problems. And so it is a form of recognizing diversity, but diversity in its broadest sense, that there are people that may have had educational journeys that were different. They may have had a family member or somebody that they care about who has experienced a healthcare issue.
How do you measure the presence of inclusive excellence at your institution?
Yeah, that's a hard one because the concept of inclusion and belonging are something that's happening internally. So that's always inherently difficult to measure. But I would say that through satisfaction scores, like we do student satisfaction every time they leave the program, they get an exit survey. We do periodic climate surveys on our students, staff, and faculty to get a sense of it. But really, my personal goal with students is that they leave our programs, one, caring about health equity and mitigating health disparities, but also feeling like for so many years, I've talked with students that were like, this is interesting, but what does it have to do with me? When students leave our programs feeling like they are equity minded, meaning that they have the skills, knowledge, and desire to change outcomes, to me, that's a measure of success.
Okay, so let's say I'm a CNO right now in a hospital somewhere in America, and I'm hiring your new graduates. What are some things that I, as a CNO, should be doing to harness what they've learned at UC Davis around diversity and inclusion? How can I harness that and help them transition to the bedside out of a student environment and then be successful in their practice, both in the day to day delivery, but also from a perspective of health equity and inclusiveness?
That's an interesting question. And obviously, for new grads, as they're coming in, they need to learn the basic skills of taking care of a patient at the bedside. Added value of some of our students is that they understand the broader perspective of what brought the patient here. Like we're seeing patients in the hospital at a moment in time, but it's not a single event usually that got them there. Like maybe somebody got in a car accident, no fault of their own. When people are coming in with chronic illnesses, there are things, there are antecedents, there are things that preceded the event in the hospital. And the better we can understand that, the better we can take care of that patient in this moment in time. And also, when we're looking at chronic illnesses, what can we do as an organization to solve some of those problems? One of the areas that I'm looking at specifically is the topic of sepsis. Sepsis is the number one cause of death in the inpatient settings, and it's often a topic that is not as talked about as maybe cardiovascular events or strokes. And not to say that those topics need to be talked about less, but if we were treating sepsis the way that we're treating some of these other illnesses, we may be able to change the outcomes of our hospitals. And so, one of the things that I'm teaching students as a case scenario is that there are disparities in sepsis outcomes based on both race and gender. And by understanding that's happening, we can start to problem solve, what do we need to be doing differently? And I would imagine that a CNO would be very interested in improving their outcomes around sepsis. And some of our students are very knowledgeable about potential strategies for solving issues such as sepsis outcomes.
So, what are some of the findings that you've found around sepsis as it relates to the disparities that exist?
Yeah. One is that there are significant disparities around sepsis for people of color, and there are disparities around gender. Why is it that there are disparities around initiation of important power bundles or sepsis pathways? We know that if a patient is suspected of sepsis and is given an antibiotic within a 2-hour window, and if fluids are started within a certain period of time, that the outcomes are much better. White men are more likely to have the sepsis pathway initiated within that 2-hour window. When you start to look at some of the other genders and races, that time increases. In one hospital, there was an 8-hour delay in initiating the sepsis bundle when a patient met the criteria for that. That's something that's preventable and is actually happening at the level of the provider at the bedside. If we can address that, like, why is it that you are more likely to start a pathway on a white male than on a Black woman? I don't think that it's necessary that we shame providers, but that we put the data in front of them and say, is this something that you intended to do? And if not, how can we support you in fixing that delay in time? The other piece of it is understanding a concept called allostatic load. Allostatic load, in just the most simplest term, is the wear and tear of the body over time in relationship to stress. So when somebody has higher allostatic load, their biological age is older than their chronological age. And so the biomarkers for allostatic load are just, again, as simple as possible: in elevated blood pressure and increased stress hormones within the body. If you think about the purpose of stress, right, it's to get you out of a dangerous situation. And to do that, the body is actually fairly magnificent in the way that it just activates the body's resources in such a way that you have the power and the energy to fight or run or freeze or fawn, any of the things that might be one of the stress responses. It's very brilliant in that. The problem is when the body stays in the stress response. So let's think about what would happen if you were in the forest. Nadine Burke Harris uses the notion of running into a bear in the forest. What would your body be doing? From the level of the cardiovascular system, you have increased heart rate, you have increased contractility, which is the strength of pumping of the heart. You have increased conductivity, which is electrical activity. And those processes increase blood pressure and increase cardiac output, which is a wonderful thing, right? You're getting the oxygen and the nutrients that you need to respond. But in a chronic way, when you're stuck there, that can look like hypertension, thinning of the cardiovascular walls, cardiomegaly, dysrhythmias. Basically, you have increased risk for cardiovascular disease. At the level of the pancreas and the liver, the body is making more glycogen, a form of glucose, in the bloodstream, and that's made available by the liver. And then there's the suppression of insulin's function of storing glucose in the cell, which is a process that is controlled by the pancreas. When this is happening chronically, like in the moment, that's great, right? You're getting extra sugar and energy, but chronically, that looks like diabetes. I want to go to the immune system. So interestingly, there's two things that happen under the stress response. You have increased inflammation, which makes sense in the moment because the body wants to staunch the flow of any bloody injury that you might have. If you're scratched by that bear, the body wants to try to clot that and deal with that in the moment. And meanwhile, it's deprioritizing immunity. So in a chronic sense, if you're stuck in the stress response, you have a more likelihood for an inflammatory response. That can look like lupus or autoimmune disorders, rheumatoid arthritis. There's an increased risk for that. And at the same time, your ability to fight off pathogens is decreased, right? Sepsis is a process of overwhelming inflammation with a body that's already inflamed, and it is an immunosuppressive process. So people that have allostatic load are very likely at higher risk for sepsis than people that don't. And just as a last sort of thing, what kind of stresses are we talking about? That can be the stress of experiencing racism, sexism, transphobia, any of those sorts of processes that are a response to discrimination, also struggling to pay the bills. I suspect that people that work in healthcare probably have a higher allostatic load because of the kind of work that we do. And healthcare providers are some of the hardest workers. So I'm very intrigued between the relationship of allostatic load and sepsis.
Has there been research studies conducted that associate or correlate allostatic loads with lower social determinants of health?
There's more of a theoretical connection that folks that struggle more with getting their basic needs met, that don't have the same access to education, high-paying jobs, that may live in an environment where you could look out the window and see some form of violence, that those are things that increase allostatic load. So there are a few articles out there around that, but I don't think that there's enough. And I would like to see some more research that more closely aligns that in a sort of quasi-experimental way rather than based on, will this make sense that this would happen?
You used the term theoretical association. Let me go to theory for a moment. What's the difference between health equity and social determinants of health. Can you help clarify for me those two terms and how they interrelate and intersect?
Health equity is an aspirational goal of where we can get. And health equity would be achieved when we have solved disparities. Health disparities are measured as the difference in health outcomes between one group and another group. The fact that homeless people have a life expectancy that is 17 and a half years shorter than people who are not experiencing homelessness, that's a health disparity right there. And that's a solvable health disparity. And the fact that African American, Native American, Native Hawaiian individuals are at higher risk for homelessness in our country makes that a racial health disparity. If we can solve that kind of disparity, we are getting to the place where we have health equity. And let me just read you a definition of health equity. This is from Paula Braveman and her colleagues. It was written in 2017 and published by Robert Wood Johnson Foundation. They say health equity means that everyone has a fair and just opportunity to be as healthy as possible. They go on to say that this requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. So they explain what health equity is. And that last sentence was basically the social determinants of health,
Okay.
right? So
Yeah.
that's the relationship, is that health equity is a goal. Social determinants of health help us think about the ways in which there are unjust and unfair practices that cause health disparities.
You were talking earlier about the data that's out there about the differences in care, particularly as it relates to race and sex in the care of sepsis patients. So, if I'm a CNO right now and I'm hearing this information, my mind goes two places. One is the shotgun approach of we need to do education across the board for everyone that this is going on and maybe share some institutional scores. The second, I think you were going to also, which is a little bit of maybe some micro performance of targeting out individuals that where the health disparities may be greater than the mean or the median for the entire organization and having targeted conversations with those. Are you aware of institutions that are doing that currently? And if so, what are the outcomes from those conversations that they're having?
Ooh, I love this question.
What should providers do differently, having that knowledge? What should nursing leaders do, having that knowledge?
In terms of individual provider strategies, one of the recommendations from the Joint Commission is that we need to solve some of the disparities that we see in our hospital, and understanding that they, as providers, are central to that. They're not just witnessing it on the sidelines, they are central to it. In terms of sepsis specifically, providers need to recognize that people who have increased allostatic load could be an indicator of impaired immunity and therefore are at high risk for inflammation and going into the sepsis process. Triage people from underserved populations, understanding that they may be at risk for the kinds of stress that contribute to allostatic load. By engaging in some safety timeouts, we do that in surgeries. That's been considered a best practice. If we had a safety timeout for any patients that are suspected of an infection, that might be helpful. And doing that in an interprofessional way, where if you are a doctor, an ER doc, or a hospitalist, you would be reaching out to the nursing staff and saying, hey, am I missing anything here? What are your thoughts on this? Or in the other way, if you're a nurse that's recognizing that somebody has the precursors for sepsis, to say, hey, can we just have a moment here to think about whether initiating a sepsis pathway would be warranted in this situation? And that, again, that idea, that interprofessional, interdisciplinary approach to clinical decisions can help us mitigate some of the blind spots that we might have around patient care. So with healthcare leaders, some of the strategies can be: one, analyze hospital level variability in sepsis outcome and risk adjusted under and over treatment of sepsis. So if you're a hospital and you are seeing that there are groups of people whose pathways are delayed in initiation, we might need to focus on that group of people that are experiencing that and the providers that are contributing to that. I think that we should share individual benchmarked outcomes with providers and initiate enhancement plans with them. And I would recommend doing that in a just culture sort of way, like we do with medication reconciliation. So I would say, don't shame the providers. Shame is not an improvement strategy, but really working with providers to see their specific numbers and talk with them about how we can improve that, particularly if you're seeing disparities within groups of people. And then at the healthcare leader level, we should have interprofessional approaches to root cause analysis for improving unit and institution-wide sepsis outcomes. So this could be the CEO, CMO, CNO, population health equity officers. This can be sepsis clinical champions, MDs that are hospitalists or ER docs, RNs, interventionalists, primary care providers. Like all of us should be focusing on sepsis from an interprofessional perspective. So again, we can see if there's any blind spots or innovation. This goes back to the concept of diversity. Interprofessional teams are an example of a diverse group of people coming together to problem solve. And we know that diversity is related to innovation and problem solving.
You talked earlier about the allostatic load and its relationship at basically putting someone at risk for sepsis. Yet, when you look at the SIRS criteria right now, allostatic load or the products that make that up is not included in that. I've heard from other colleagues that the SIRS criteria is really not an effective means of identifying or risk stratifying sepsis to begin with. So do we need to just blow everything up and then maybe start from scratch with some new sepsis identification tools that are valid and reliable tools that also to take into effect social determinants of health and diversity?
That is basically my recommendation. Absolutely. That we start to look at sepsis in new ways. The term allostatic load is getting used more in the common conversations across healthcare. And yet I do run into places that they don't know the term allostatic load, and that hasn't really occurred to them. In fact, I was working with a group of physicians and RNs from a prestigious institution, and they're like, wait, that makes sense. And we've never had that conversation before. Let's talk about this more. And because there was that level of interest, I would like to engage in more research that could see if there is a connection between allostatic load and sepsis outcomes. Like, really, we don't know why some people go into sepsis and some people don't, even when they have a similar clinical presentation.
You also talked earlier about how healthcare providers in and of themselves and nurses tend to have likely a higher allostatic load just from the nature of our work. There's been a lot of talk recently, especially since COVID, about work-life balance and improving the healthy work environment that exists in the area in which we operate. Any recommendations that you have as it relates to that?
In terms of solving the issue of allostatic load for healthcare providers, there's so many layers of that.
Right.
Is basically the social contract that we have in our country about what is expected of healthcare providers. We know that in our country, we have the most expensive healthcare system in the world, but not necessarily the best outcomes. We also have some of the best paid healthcare providers in the world, right? And I'm not advocating for changing that, but part of what happens is that we know that you're getting paid really well. So our expectation of you is, yeah, work 12-hour shifts. In fact, yeah, work 6 12-hour shifts in a row. We saw our folks showing up during the pandemic in a way that I believe is deeply costly. Yes, it's heroic that our nurses showed up every day working extra shifts, doing some of the hardest work possible. We call them heroes, but what was the cost to them in terms of allostatic load? What are the health outcomes? We saw that there were a lot of healthcare providers that caught COVID and passed away because of that. So the expectations of healthcare providers is really high. And I think it's dangerously. And then on the back end of it, and I'm just going to give you a personal experience as an ER nurse and an ICU nurse, I experienced having babies. All of my babies came early. And I was working up until 2 2 weeks before I actually gave birth. And that's the expectation, is that we work so very hard in this country. And then on the flip side of it, how much time did I get off for maternity leave? 6 weeks. So I was right back at it. That's exhausting. I couldn't help but wonder if me running up and down the hallway for 12 hours might not have contributed to all of my kids coming somewhat early, or one of them was significantly early. Is that part of the stress response that's happening? If you're stuck in the stress response, guess what's getting deprioritized? All of the things that happen with the parasympathetic system, which is the feeding and breeding part of it. So I don't have concrete evidence to say that nurses and healthcare providers have allostatic load, but I sure am curious about it. There could be a correlation there, and I think that is worthy of inquiry and research.
Can you tell me a little bit about this Summer Health Institute, what inspired its creation, and how it's shaping the future of nursing?
Yeah, and I don't know if you can tell from my voice, but I'm smiling because this is one of my favorite topics. The idea with this program is that we want to catch people at different periods of their pathway toward nursing and healthcare. We can start with preschool all the way up through people finishing nursing school, becoming faculty members, getting their terminal degree. Every point of that pathway is important. I've spent a lot of my career looking at pre-nursing and nursing students, their education, their retention. It's just as important to get people through the program as it is to get them into the program. So I have done a lot of research in that area. I wanted to go back a little bit farther, and I landed on high school students and early community college students. And one of the reasons is that I've worked with so many students that are in college and are pre-nursing students, and they've made mistakes along the way that really has cost them dearly, and sometimes things that aren't fixable, right? If you have a 5-unit F in chemistry that you are not able to fix, like, those are things that can actually stop you from being successful in getting into a nursing school. Nursing schools are hugely competitive. We were just looking at some of the statistics for some of our nursing schools in the University of California system, and we're finding that it was harder to get into a nursing program than an Ivy League college. If we could catch students early in their educational trajectory, we might be able to help them look at and understand the academic journey in a way that prevents them from making some of the mistakes that might cost them the ability to get into nursing school. So the Shines is a 2-week summer health program. We bring students onto campus each day. They spend about 6 hours with us each day, and we go through a myriad of topics. Some of them are directly related to healthcare. They get a CPR card. They get their training here on campus with our healthcare providers from UC Davis Health. They have simulated experiences, so they're learning how to dress wounds. They're learning how to look into an eye, into an ear. We show them how we teach students to insert an IV. They get an opportunity to see our high fidelity simulation mannequins working in the moment. Sometimes we do like a code blue so that they can get a sense of what that looks like. They also get training on how to build a resume and a cover letter and the kinds of things that go into that resume to make it competitive, like volunteer experiences or getting their CNA certification, and how do they go about doing that. Some of the other topics are specifically social determinants of health. And we also have a Race and Health Institute that is run by Jan Marie Garcia. She's one of 2 women that coined the term cultural humility. So the students get 2.5 days of training on what cultural humility means and what their identity means in terms of interacting with patients, and really an understanding that their identity, their life experiences, any of the things that they've had to overcome in their life is not something that makes them less qualified to be a healthcare provider, but rather more qualified. And so we've experienced students feeling like nursing was something that they really wanted to do and something that they were capable of doing. They through our evaluation metrics. We give them a pre and post survey. We do session surveys, we've done focus groups, and we do a longitudinal check-in with our students that have participated in the program. And let me just give you a couple of examples of students that have done really well in our program. One of them was in our first cohort. He was a student that let us know when he came in that he was a little bit ambivalent about joining the Shines, but his mom was a nurse and thought it would be a really good idea for him, but he wasn't so sure. He left the Shines program saying, I had no idea this is what my mom did. Nurses are really cool. And he very much pursued getting into nursing school and is actually in nursing school and is coming back to volunteer and support our current Shine students. So that was just a beautiful story of when we put students in front of nurses, when they understand what they can bring to the nursing profession, they're more likely to, one, want to be a nurse, and two, feel like they can be a nurse. We also had a student in a recent cohort who was having a hard time figuring out financially, how can I make this happen for myself? So we have worked with him on multiple occasions, trying to get him opportunities that would make him competitive for healthcare provider jobs. And we also found some temporary employment for him in our School of Nursing, such that he was getting some of those valuable experiences, hanging out with people that teach nursing to really see, is this the path that you want to go? And finally, I want to say that even if there are students that come through the Shines program that say, nursing may not be for me, I think of that as a win, particularly if they're still interested in academia. If somebody doesn't want to be a nurse, I want them to find that out as soon as possible before they invest time and money and energy and they sacrifice for this thing to find out it really wasn't for them. So we did have a student a while back. I saw her maybe a year after Shines, and she sheepishly said, yeah, I loved Shines. It was a great experience. Turns out I don't want to be a nurse, but I want to study law. And I was like, I love that for you. That to me is a success. If they still feel like they want to pursue a profession and that they can and will. So anyway, we're very proud of the Shines program. At this point, we've served 141 students over the last 4 years. We are really proud of the impact that we've made as a program.
Any closing thoughts as we wrap up this episode?
If we think of the struggle for justice, equity, health equity over time, there have been peaks and valleys. After 2020, I felt like we had a resurgence of energy around racial equity, where we made really important strides over time. And that movement has radically changed with the new administration. And I think for many of the people that have been passionate about mitigating disparities in any form, but particularly health disparities, there's a feeling of hopelessness, despair. We feel shaken by some of the changes that have happened. And I want to remind people that this is a long-term journey and we are going to continue our work no matter what. Our work is based in science. Our work is based in the ethos of our respective healthcare professions. This is the work that we have signed up for and that we will continue to do. And it's better to do it at a steady pace. And this means that we need to take care of ourselves. We need to invest in wellness, and wellness can be considered different things. I'm talking about the kinds of things that help you get out of the stress response, whatever that is for you. Some people it's exercise, sometimes it's reading. It might be being with the people that you love and laughing, but really giving yourself the space to do those things that can stop the cycle of stress. The other piece of it is we got to take care of each other. And I just want to say that again, we've got to take care of each other. And this can mean, your coworkers. This can mean your community members. This can mean people that would potentially be allies if they felt like there was a space for them in the work that we're doing toward health equity, a really important task. So taking care of ourselves and taking care of each other is probably the best investment we can make in continuing this really important work towards health equity.
Promoting health equity and wellness has been our episode topic. Dr. Piri Ackerman, thank you so much for your time today.
Wonderful. Thank you for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.